us. We're just giving it just a few more seconds as people are joining. Okay, people may continue to join the room, but I am going to go ahead and get started because we don't have a lot of time today and we have a really packed agenda. So good morning and good afternoon, everyone. And welcome to the local partner session on optimizing service delivery to meet patient preferences. In the next hour that we have, 55 minutes, we'll have presentations on multiple differentiated service delivery models, including multi-month dispensing and decentralized drug distribution. And we will have time at the end for question and answers. So my name is Ashley Grieve. I am a supply chain advisor at USAID Washington. Let's go ahead and advance one slide. I will be moderating today's session, and just before we begin, a couple of housekeeping items. So you can click on the bottom of the screen where the globe is. If you need translation, we have options for French and Portuguese. Secondly, if you do have any technical difficulties, you can't hear us or something goes wrong, you can put that in the chat and we will try to get you some technical support as we go along. And then finally, if you do have questions as our panelists and presenters are going along, feel free to just put that right in the chat and we will circle back to it. We'll do our best to answer as many as we can as we go along and then at the end when we get to the Q&A. So we're really excited to host this session today, which features experiences and lessons learned from our panelists and our partners in Uganda, Botswana, and Haiti. We will have our panelists give a short presentation on their findings, each of them, and then I'll kick off a Q&A discussion for, again, hopefully the last about 20 minutes. So while these models that we're talking about, MMD and DDD, are not necessarily new to PEPFAR supported countries, we know they continue to be absolutely crucial aspects of the COVID-19 response in decongesting our health facilities and also in ensuring uninterrupted treatment to care for our patients. I'd like to go ahead and start our sessions by introducing our first presenter, Dr. Emeline Emmanuel from the Institut pour la Santé in Haiti, and she will be presenting on sharing confidential data to support the continuum of care and flexibility for ART patients who might be subject to frequent mobility. So we did have to do a little bit of rearranging of the slides. We're gonna go ahead and find the appropriate section for Dr. Emmanuel. Oh, and we're already there, great. So over to you, Dr. Emmanuel.
Good morning, everyone. It's a pleasure to be with you. I'm going to present a platform ISPD developed to share patient data across HIV sites for patients to ensure continuum of access to quality of care, and then hopefully to improve treatment retention and ensure viral load suppression. Next slide. Oh, the name of the project is Bridge. Bridge is a differentiated HIV service delivery project for priority population, focusing on men, mobile population, and migrants in Haiti. Bridge was awarded in December 2019. We have sites located in the capital, in the North region, in the Southern region, and in both main and border entry that we shared with Dominican Republic as well. So when a patient moves across the country, even though all the HIV sites use a national EMR, you don't have access to the patient chart. You can access only your patient chart. So when the patient moves, the next provider doesn't have the clinical data to do the follow-up. So as we are dealing with mobile population, we think at the beginning of the project that
Dr. Emmanuel, you're on mute.
Oh, okay.
I think we missed just the last sentence that you said.
Okay, so when the patient moves, as we are dealing with mobile population, we have to ensure that when this patient moves, the provider can have the data, not only to continue the care, do a refill, do a blood draw for viral load testing, but also to document that they deliver these services to this patient, so the parent side doesn't list this patient as someone who has interrupt treatment. Next slide. Okay. This is an overview of the system work. First, we have on the right side, the EMR. We have 3 EMR in Haiti, but the main one is eSanté. All these EMR share data with a platform that's called SALV. SALV is a national reporting electronic platform that integrates all the HIV data in one single data set. So our system, the VIP card system, took the data from SALV and shared the data back with SALV. And when the patient arrives at a site, it receives counseling, and if he agreed to, he receives a contactless card, a smart card. And with this smart card, he can access his clinical data when he arrives at another facility. Next slide. Okay, this is how it works. The main facility issued the card. Now the patient arrives at another facility. The card is inserted in a reader. At the same moment, the patient data come off. We have security questions to ensure that this is the patient we are dealing with. And then the provider can do the follow-up. He can document a clinical visit, a refill, or lab specimen draw. And when he finished to enter this data on the system, there's an alert that is sent back to the first sites, and they know that the patient received this service, and they can go back in the patient file to update his data. Next slide. This is a screenshot how you can look for a patient on the system. The main option and the quickest one is just to scan the card. But we have other options, like if you know the name of the facility and the code of the patient file, you can look with these criteria. Or there's a code number on the card. You can look for the patient data with this information, or you can use the patient fingerprint. Next slide. This is a screenshot of what you have when you access the patient data. We have a listing of the last 10 clinical visits with the date, what have been done, like which medication have been prescribed or dispensed, the last date for the viral load and the result. You have also, if the patient have allergic or something as medical history like hypertension or substance use, this will show off as well. And in the header, you have the demographic data, contact information, the regimen, the status at the main facility, etc. From this view, the provider can add a new clinical visit, it can document a new dispensation, or a blood draw for a specimen collection for a test. Next slide. ISPD put in place also a toll-free hotline that can be accessed from the main communication network in Haiti. So if a patient moves and is looking for HIV services, he can call this number and we will refer him to the closest one when he can receive services. And we know that the main sites will be alerted. The same number can be used by the provider as well if there are any technical issues with the system, and they will be directed to a project staff. This number is on the card, so it's easily accessible for the patient. Next slide. As September, we have issued like 760 cards, mostly for patients that disclose their intention to move, or for patients that are in satellite sites, so the main facility can have these clinical data. We are working with 2 other implementing partners. There's Health to Walls, who provide HIV care for prisoner or former prisoner and their relatives. And there is ECP2, which provide HIV clinical care for key population. So in the both groups, they use it for mostly at this moment to link it the satellite sites to some main facilities. But especially for key population, there's an interest because there's a lot of mobility in this category. Next slide. Okay, so far we have like 16 visits done on the system. It's not a lot because the system is new and the patients are receiving multi-month scripting. But what we have seen so far, that's first is quick. When the patient arrives, it's quick. And it's also there's a flexibility for the patient. For example, last week, we have a patient from the capital that was at the northern border and he needed a refill. So it was easy for us to refer at the facility we have there, and then to do the follow-up in the main facility was well. And this allows to the provider to have the right clinical data to do the follow-up, that's which regimen. If the patient need a refill, to know if the patient need a blood draw for viral load testing. For the next period or for this year, we plan to expand in other network, and it will be great also to be able to use the system for patients who move to the Dominican Republic. But there's more discussion to be done on this and between Ministry of Health, the implementing partners, and the donors. Next slide. Okay, that's it. And we work mainly with the Ministry of Health on this project. With USAID, we grant the branch award, and with the 2 other IP I mentioned. Thank you.
Thank you so much, Dr. Emmanuel. This system that you raised with the VIP cards and the ability to track patients and ensure collaboration between sites is just really critical as we're seeing more and more decentralized drug distribution sites. And the question is raised as to how we're collaborating, how we're tracking data, as more flexibility is built into the system. So this is a really interesting example that you've shared with us today. And as a reminder, we'll circle back to questions at the end, but do feel free to please put them in the chat as we go along. So I do want to move to, we're going to introduce Dr. Nkoyo-Oyo, Dr. Abdallah Nkoyo-Oyo. I think if we could go to we're finding the right slide, apologies. We had just to rearrange some of our slides this morning. So just as a brief introduction, Our next speaker is a project director representing the AIDS Support Organization, or TASO, in Uganda, and will be presenting on TASO's findings on solutions for scaling MMD during the COVID-19 pandemic. So we'll go through all the presentations, questions at the end, and go ahead, over to you, Dr. Nkoyoyo.
Thank you very much, actually, for this opportunity to present at this conference. I'm going to present highlights, innovative solutions to scaling up multi-month dispensation during the COVID-19 pandemic. These are lessons learned by TASO in Uganda. So I'm representing a team from TASO, which was able to put up this presentation. I am Dr. Nkoyoyo Abdallah. I'm the project director for the USAID Local Partner Health Services Project in Ankole region. Next slide. So, as a background, we know that multi-month dispensation of ART refills remains a critical towards reducing health facility visits, especially during COVID-19 pandemic. However, its scale up in Uganda has been very slow. So now in this presentation highlights and assesses strategies that we used to improve uptake of multi-month dispensation in Uganda. Next slide. Well, we had different methods that we employed. We analyzed multi-month dispensation data from October 2020 to June 2021. And we had an analysis at the midpoint that was in February 2021. And we conducted at that time a rapid needs assessment that listed key barriers to multi-month dispensation. And we had put up strategies to scale up its acceleration in the region. Now, we had evidence-based strategies that we employed to ensure that we improve multi-month dispensation in the region, and amongst which we included, we conducted mentorship and technical assistance to health workers in the region to be able to take on multi-month dispensation and apply to all the clients that were eligible in the region. We also strengthened the supply chain for both logistics and drugs to ensure that there are adequate logistics and drugs in the region to support the multi-month dispensation strategy in the region. We also took efforts to improve community access of multi-month dispensation in the region where we operate. Another slide. As far as health work mentorship was concerned, we supported health workers to be able to update the data collection tools. We have different data collection tools that support multi-month dispensation, including audit tools, including registers, and so on, and other registers that are at the facility level that give information about who is eligible, who is due, and who has missed his refill. So we also took health workers through an extensive use of an audit tool, which is a tool that is used to follow through clients that are due and eligible for different services, so that the health workers are able to follow through who has missed and who has not missed. So this tool is very important for us to be able that we take stock of every individual who is eligible for a service to ensure that he has access to that service on time. So we also took through health workers in their ability to improve categorization of clients to ensure that all those that are eligible for multi-month dispensation have been identified and enrolled onto the system, and those that are not eligible are followed through to ensure that by the time they become eligible for the service, they are given the service on time. We also mentored health workers on the updated multi-month dispensation policy guidelines by the Ministry of Health, which highlighted that we are supposed to delink viral load bleeding from multi-month dispensation and initiating clients on MMD after 3 months of treatment. So the Ministry of Health gave policy guidelines that help
Making sure, I think we lost you right after policy guidelines. Oh, can you just go back about 10 seconds?
We have mentored health workers to understand the guidelines that had been issued by the Ministry of Health, which directed that viral load bleeding should be linked from month-to-month dispensation. So before, people would wait for a person to come back for viral load bleeding so that they dispense month-to-month dispensation. But this guidance gave way that even if somebody is not yet due for viral load bleeding, it should be given month-to-month dispensation so that we improve uptake of month-to-month dispensation in the country. Next slide. As far as strengthening drug supply chain is concerned, we mentored our health workers at the health facility level to be able to understand how to accurately measure and quantify drugs that are needed in their facilities so that they are able to place good orders for drugs that will be able to help them go through the specified periods of their class they serve. Now, at the same time, we're able to go through the different facilities that we serve to identify facilities that were overstocked with drugs and redistribute these drugs to the facilities that were understocked so that we create availability of drugs to all the facilities at the same time to be able to deliver month-to-month dispensation to the clients that come to their facilities. Now, we also supported medicines management supervisors who are at district level to be able to follow through the efforts we have made at the facility level, to follow through the health workers to be able to make timely and accurate drug quantification and ordering. Next slide. Now, for us to be able to improve community access for month-to-month dispensation during the COVID era, we allowed clients from different facilities who had been restricted from movement from one community to another to be able to access freely month-to-month dispensation drugs from the nearby health facility. Because in my country, there are some clients who do not register for ART in the nearby health facility. They prefer going to different facilities because of different reasons, including stigma as one of the reasons. But during COVID restrictions, they could not move freely to go and access their drugs from their facilities. So we allowed health facilities to allow these new clients to come as visitors and take up month-to-month dispensation. And then we would collect this information and relay it to the mother facility for updating the system. We also conducted community viral load and drug dispensation delivery. So we would go, we use peers, we use different structures in the community to go and look for the clients that are due for drug refills. And then we deliver the drugs in the community because they could not move freely during the COVID restrictions. We also engaged the community stakeholders like the district local government to allow our health workers to move freely in the community to be able to deliver the drugs in the community. We use the key population peers, we use the young and adolescent peers, we use the linkage facilitators, we use the village health teams to be able to refill drugs to all the clients that are due for month-to-month dispensation in the community. We also did a lot of patient literacy on the benefits of month-to-month dispensation and on how to access the drugs during the COVID-19 restrictions. So we used radio talk shows, we used community megaphones, we used also to relay information through the opinion leaders in the churches, in the mosques, and other public places. Next slide. So we assessed the impact of our innovations. We looked at data, monthly proportions of MMD. We compared the baseline data that was in October 2020. We also looked at the midpoint that is in February 2021, and also at the end point in June 2021 to see the trends in achievements using proportion tests. Now, we tested the month-to-month dispensation data uptake trend using chi-square for trend test, and we also use the starter version 14 and other software to aid statistical analysis. Next slide. When we looked at the results, we noted that the number of active clients on ART were 71,320 at the baseline. That was in October 2020. And they had risen to 74,124 at midpoint in February 2021. And then finally, by the end of our study, we had seen that the number of clients after our implementation of those different strategies during the COVID-19 restrictions, the number had risen to 77,200 at the end point. Now, we also noted that the proportion of MMD was highest at the end point compared to the baseline. And we also saw that these are the chi-square values, and this was significantly, statistically significant during those periods. Next slide. Other results at the end point, we realized that we noted that MMD uptake was significantly higher among males compared to the females with a p-value of 0.001. It was significant. We also noted that it was higher amongst adults aged 15 years and above compared to the children. The uptake was higher amongst adults compared to the children and adolescents who were under 15 years of age with a p-value of 0.001, which was also very significant. Now, further analysis also revealed that the monthly proportions on MMD was significantly increased over time. So as time went on, from the first month, second month, up to the sixth month, the proportions increased significantly over time. And the increase was steeper among the children under 15 years of age. Next slide. You can see this slide, it was showing trends. The figure of 2508 was supposed to be 2415, but this figure was trying to show a cascade of individuals because during that period, we enrolled 2,415 new individuals on ART, but when you look at the 77,872 individuals who were current on ART at that time, 95% of them were eligible for viral load. And out of those that were eligible for viral load, when they were bled, we found that 92% of them had suppression figures. They were virally suppressed. Now, those individuals gave us an opportunity to enroll many individuals as long as they understood the benefits of MMD. So it gave us opportunity to enroll many of them onto MMD. And at the end of it all, about 80% of them were enrolled on multi-month dispensation of more than 3 months. Next slide. This figure just highlights what was happening. As many people were taking their drugs properly, you can see that the viral load coverage increased over time from the first quarter and the second quarter. Many of the districts, these are the districts which are covered by you can see now in the second quarter, quarter two, we had a district in red for viral load coverage less than 80%, but in the subsequent quarter after implementation of different strategies, the viral load coverage also increased to above 80% for all districts. And next slide, and that one actually gave us opportunity to have more virally suppressed individuals because we're taking their drugs properly, and as a result, many people were being enrolled onto multi-month dispensation. And this one is also showing the coverage, the suppression rates. This is what was providing us a good ground for us to enroll more and more individuals on MMD, because you can see in the quarter two of our period, about 7 districts had suppression rates of less than 90%, but you can and even more than 6 districts had registered suppression rates of more than 90. So it was giving us good ground to enroll more and more individuals on MMD. Next slide. Now, this shows us the trends and the monthly proportions of people living with HIV on MMD during our study period. You can see in the first graph that as the individuals who are on less than 3-month refills decreased, it was significantly shown that those individuals who are being enrolled on multi-month refills increased steadily, as the ones on less than 3 months refills were decreasing significantly. But you can also see in the second graph that this increase actually was proportionate in both males and females. We registered increase in both females and males uptake of multi-month dispensation, although it was more significantly observed amongst males than in females. But you can also see in the last graph that there was a very stiff increase amongst children, among children. Less than 15 years of age, because there was an effort to ensure that all children who are eligible are also enrolled on multi-month dispensation to improve their retention in care and also to improve their quality of life. Next slide. So in conclusion, the proportion of individuals on multi-month dispensation rapidly increased following our mentorship and technical assistance to health workers on multi-month dispensation in the region. It also increased following our strengthened efforts on improving the supply chain for both drugs and logistics in the region. And finally, it was also the improvement was contributed to by the improvement in community access to multi-month dispensation. We therefore recommend the above strategies to accelerate multi-month dispensation in similar settings. Thank you. Thank you. That is the end of my presentation.
Thank you so much, Dr. Nkoyoyo. The strategies that you've shared, I think are very practical and can be definitely replicated in other contexts about the mentorship to health workers and the variety of tactics deployed to improve community awareness and access. And as a supply chain advisor, it's very near and dear to my heart that you also mentioned supply chain strengthening and making sure to support ordering and getting the right commodities in the right quantity in the right place. I think that people do often forget about supply chain unless it's not working, but when it is working, people forget that DDD and MMD both rely on a strong and successful supply chain. So all of your recommendations are very good. Thank you for that. And I do want to turn to our third and final presenter before we can open up to questions. So I would like to introduce Dr. Gaune Makwinja. Dr. Makwinja will be speaking about Tebelopele in Botswana on a number of differentiated service delivery models. So that will include MMD and DDD and really pull this together in an ecosystem of differentiated models that have been successfully implemented. So let's go ahead over to you, Dr. Makwinja.
Good afternoon, everyone, and esteemed colleagues that are on the platform. I am very honored to be part of the panel discussion today and very excited to learn from other implementing countries on issues around continuity of care for treatment for people living with HIV and AIDS. So I'm Dr. Gaune Makwinja. I'm the technical director for the Kgathalopele mo Botsogong project, which is a project that started in January 2021, directly receiving directly receiving funding from USAID. Initially, we were receiving funding through FHI 360 as a sum. So since January 2021, we were now directly funded under the FAA funding. So next slide, please. Just to give a background on our project, the name of the project is Katelopele Mobutso Home Project, funded for 3 years under USAID, and we were technically supported by FHI 360 in the beginning of the project. Next slide. So basically today I'll be talking about strategies that we implemented as a facility to ensure continuity in treatment during the COVID-19 epidemic. So basically in Botswana, on the 30th of March 2020, we recorded our first case of COVID-19, and immediately following that, on the 2nd of April, the government declared a state of emergency and subsequently imposing an initial 28-day lockdown. So that means there were people that were allowed to travel freely around the country, and if you're not part of the essential services, you're not allowed to travel freely without a permit. So therefore, clinicians, as part of the essential services, we had to sit around and come with interventions or implementation methods that we can go and provide services for clients to ensure continuity in treatment and reduce treatment interruption during this COVID-19 time. So we implemented differentiated service delivery models across our facilities. Next slide. Where our facilities are in Francistown, Gaborone, and Gwening East. Gaborone being the capital city of the country, and Francistown, and another big district, which is Gwening East, where we see Mulapolole. Next slide. So we started initiating about 4 different models in collaboration with our community partners, CAPE and HPP, and also through partnership with the Botswana Post for post office deliveries. So we implemented 4 different models, that is the multi-month dispensing, facility fast-track refill model, community medication refill model, the decentralized drug distribution models. So the MMD basically was more to reduce the frequency of medication refills for people living with HIV, the fast track facility refill model to reduce the time that clients spend when they come to the facilities for the refill, and also community medication refill together with the DDD to ensure that we bridge the gaps surrounding social constraints, that is work constraints, whether someone doesn't have the funds to come to the facility. So all these models came together to ensure that even during these times, our clients continue to receive care. Next slide. So we had an eligibility criteria, this one specifically for enrolling clients on MMD. We followed that they had to be more than 12 months on treatment. They have to be an adult of more than 18 years old. They're on first line ART regimen. They've been on the same ART regimen for more than 12 months. They've had 2 consecutive undetectable viral load, no active TB, and also no any other clinical conditions that require regular follow-up by the clinician. Next slide. So just to note something here, that MMD is not used as a prerequisite to be enrolled on other DSD models. And also noting that pregnant women and breastfeeding women are also eligible for the DSD models, where we align the refill appointments together with the ANC or the postnatal care appointments. So under the facility fast track refill model, we ensure that once the client comes to the facility for their refill, once they reach the facility, they go straight to the refill station. They don't have to see a clinician, where they will be able to see whether a healthcare assistant or a case manager to provide them with their medication. All these medications are pre-packed by our facility pharmacist, and they handed over to the healthcare assistant or the case managers to refill for the clients. So we did an analysis of our data for the reporting period where 88% of our clients who came for their medication refill at the facility, they spent less than 15 minutes in the facility. Next slide. So this is just a picture of what we call our Gazebo strategy. This gazebo is set outside of our facility, which is the first point of contact for our clients when they come into the facility, where the staff member, a trained staff member, is able to establish what the client is there for in the clinic. So they're given color-coded numbers to go to their respective service provision points. For example, we'll give a green number for refills, so that client will go straight to the refill point where they're going to be refilled for. At this point, we're able to record the arrival time of the client and also record the time when they were provided with the refill. Next slide. Another model that we are currently implementing is the community medication refill, where similarly a pharmacist pre-packaged the medication and they're handed over to a community healthcare worker through partnerships or collaborating with our community partners, Weve and HPP, where then these community healthcare workers take the medication to the clients in the community. Clients can receive 1 month refill, 2 months refill, or 3 months MMD. Next slide. So this is just a picture of our pharmacy technician handing over the medication to the community healthcare worker in our facility. Next slide. So the decentralized drug distribution model, which was supported through FHI 360 by the EPIC project, engaged the Botswana Post for post office delivery of medications, and also partnered with a private lab for viral load testing. So these models, they were, like I've mentioned, they were supported through FHI 360 through the reporting period. Next slide. So following which, when you look into our data, as at June 2021, we were at 98% retention rate, where we had 658 clients currently on treatment across all the 3 facilities. Just bear in mind that this is just a portion of clients that we transitioned from the APC 2.0 project. So that is why we have 658 clients that were currently on treatment as at June 2021. Next slide. So of the 658 clients, we have 99% of them on TLD. Next slide. So this is just the consent form or questionnaire that we administer at all review appointments for our clients. This consent form is meant to establish the DSD model preference of a client at that particular time, and also establish if they have a new address or a new telephone number. So this is implemented, or it's asked, clients are asked this consent form at every review appointment. Next slide. So out of the 658 clients that we had on treatment, 61.5% of them enrolled for the DSD models using the questionnaire or the consent form that we implement at all visits. So there we see 45.4% of our clients is re-enrolled for the facility fast track refill, and then 43.7% enrolling for the DDD model, and then 10.9% enrolling for the community medication refill models. Next slide. And also through partnership with the private lab, we are able to achieve a 99% viral load coverage and 99% suppression. This, the reason why I'm highlighting the viral load coverage is that also during the COVID-19 epidemic, in the beginning, we realized that the national lab where we were traditionally doing our viral load, they switched or shifted the staff members more to COVID testing than viral load testing. Therefore, the turnaround time for our viral load results started being longer, more than 2 weeks. So with the engagement of the private lab, where we have a turnaround time of less than 24 hours, it was able to assist with improving our viral load coverage and achieving the 89% viral load coverage and 99% suppression, where we only have 3 clients who are not suppressed, and they have been engaged on enhanced adherence counseling to ensure that they are suppressed. Next slide. So what have we learned so far? We have learned that clients alternate between the DSD models depending on their needs at the time of the review. Some clients might have relocated from their previous address. Some clients might have a new partner who they haven't disclosed their status to. So therefore, you can't do a community medication refill or do a post-office delivery yet. So that is why we continue to probe or consent at every visit to ensure that the same status of the DSD models in the previous visits continue to be the same, or they have changed from that preference. So it's very, very crucial to ensure that we continue monitoring clients' preference at every visit. And one of the things that we've also learned is that clients in the big cities, in the capital cities, they tend to prefer facility fast-track refill model as compared to those ones in the rural areas where they prefer community medication refill and the post-office delivery. This is just, I think, it's just because of different challenges in these geographical settings. Next slide. So in conclusion, we are planning on scaling up the DSD models because we've learned that they decongest facilities where you have, as you've seen in our data, 61.5% of our clients serviced through the DSD models. Therefore, it's assisting with decongesting facilities and having clinicians focus more on patients that actually need clinical attention, and also being able to reshift our time to more other consuming tasks in the facility and have other staff members assist with the DSD models. And like I was saying, that the other conclusion is that client needs may change at every visit. Therefore, it's very, very important to continue prompting on the preference of the DSD models. I think that is the last of my slides. Thank you so much for the opportunity.
And thank you, Dr. Makwinja, and to all of our wonderful presenters. I think this finding and reminder that you're giving us about constantly prompting patients to reevaluate their preferences over time is so important for us to consider across all countries and across all of these models. We're getting some questions in the Q&A that I do want to go back to. And I'm just going to start, though, by throwing out a question to all of our presenters on how do you think a healthcare system should be evaluating the universe of options for patients and picking which service delivery models or combination of models are appropriate? I say this specifically because I have heard people say, you know, in countries where MMD or especially is widely available, do we even need differentiated service delivery models? So what do you think about the options and how to make sure that the right combination is available?
Let me go first. In Haiti, for example, for some patients, even when we offer them multi-month scripting, they don't want or they don't have somewhere to store all these medications. So they prefer to have little stocks. So it's better to have multiple options so we can adjust to client preference. And they can lose their stock as well. We had this issue with the earthquake in the south in Haiti, so we had to refill the patient. That's an example, but this is happening.
Definitely. Do others want to weigh in on that?
Yes, I think the MMD and other DSD models can coexist in a clinical setting, because if you look at social constraints and people's life continuously changing, for example, one person might have a new partner that they don't want to disclose the status to yet. So those options being availed for clients are able to help or assist with the social constraints that keeps on existing around people living with HIV. So therefore, I think they need to run parallel to each other or coexist. So I would still maintain having the MMD and the DSD models running concurrently in the facilities.
A good point as well. There are some questions about consent that I see here. And indeed, clinical data is starting to show that some patients don't want 6-MMD and prefer to be able to see their providers more frequently, or scared to be away from the facility for so long. So how are patients able to select in or not select into these programs? Does anyone have a comment on how that works in your setting? I think that's a good question for MMD or DDD. Yeah, go ahead.
Okay, can you just repeat the question one more time, please?
Yeah, are patients asked to consent to MMD so that if they don't want 6-month MMD, or they don't want a particular DDD option, how do they choose to opt in or opt out?
Like I was saying, in our setting, we have this questionnaire that we ensure that we ask our clients at every visit. The first key consideration is, do you want to be part of this DSD models? Do you want to receive MMD? Do you want to receive DSD models? It's a question that we ask them. It dependent on the client whether they want to enroll for these models. So it goes back to the client's choice and client-centered approach. So therefore, we don't force it on them. So it's all client-centered. If they still prefer to come to the facility every month, then we enroll them on the facility fast-track refill model.
I'm working mostly at the IP level. So I'm not working at the facilities, but I do note that some patients receive the DSD option. For example, when we set up our men's health clinic, so we make them so happy to the clients when we offer them to receive the medication in the community, they prefer to come back to the facilities.
And Dr. Nkoyoyo, I see you have your hand up as well.
Yes, the DSD model definitely means that the differentiated service delivery models mean that we are supposed to give clients according to their preferences, not that we are forcing this onto the client. So we are giving the best according to the client preference. That is the differentiated service delivery model. So, but we give information to the clients for them to be able to choose the best. Now, in this case, we think that they should choose to get a refill for more than 3 months or more, because it will reduce their coming back to the facility more frequently. We think it is the best for them. So when we give them that information, most likely they choose to get the MMD. But there are some clients, because of the different reasons. For example, we have some facilities which are along the lake shores. So the fisher folks get into the islands with their drugs. So they cannot, most of them cannot keep drugs for 3 months because they get wet with water and they get spoiled. For them, they understand the importance of MMD, but they tell you, we cannot keep the drugs for long. So they prefer to get 1 monthly refill, times even shorter than that, but they cannot take on MMD, but after understanding that it is good for them, though they cannot be able to keep them safe. So MMD, rather differentiated service delivery, is for us to be able to deliver the best to the convenience of the client. So they can choose to have more than 3 months, but they can also choose to have less than 3 months. And we absorb both of the clients types. Thank you.
Ashley, you're on mute. Sorry, you're on mute.
Apologies. Thank you, everyone. I wanted to just thank all of our presenters and see if we could ask just one last question before we run out of time and our interpreters have to move on. We saw a lot of really impressive viral load suppression results as we were going through these presentations. And so the question is there observed variation in viral load coverage based on these different models? And can anyone speak to that based on your program and findings? Or any more successful in viral load suppression than others? That might be a thought for us to chew on. Dr. McQuinje, did you want to take that?
Actually, can you just repeat that question once more so that I understand exactly what?
Yeah, the question is about viral load suppression and what are the differences between the different models? Are some more successful?
I think you are raising a great point that we as a program, we can look into and establish the viral load suppression amongst our different DSD models. So I think it's something that we can look into as a program, and it will be something great to share, to really dive into the data and see what is happening with regards to the viral load coverage across all the DSD models.
Thank you. And I think that just goes to show that we're still learning as we continue to scale these models across countries. Thank you so much to our presenters. This was wonderful. I apologize we didn't get through all questions, but we have captured them. So I'll see if there's a way for us to be in touch. I'm not sure. Thank you so much, everyone, for your time. And we'll let you go to your next sessions now. Thank you, everyone.